Assalamualaikum everyone. Good morning. I'm Dr. Misal Javed, Resident Urology, and today we will be talking about lower urinary tract infections, and we will be covering urethritis, prostatitis, cystitis, bladder pain syndrome, and chronic pelvic pain syndrome. Beginning with urethritis, it is an inflammation of the urethra, which is a very common manifestation of mainly the sexually transmitted diseases, and Neisseria gonorrhea and chlamydia trachomatis being the most commonly identified organisms. It is primarily classified into two types, gonococcal and non-gonococcal urethritis. In gonococcal urethritis, Neisseria gonorrhea is the relatively common cause, and other sexually transmitted pathogens are also found. Even Neisseria meningitidis has also been reported as a cause of symptomatic urethritis in men. Non-gonococcal urethritis is most commonly caused by chlamydia trachomatis. The patients will present with complaints of dysuria, burning, pruritus, and discharge at the urethral meatus. The discharge may vary from a mucoid or watery consistency to a purulent consistency. It may be present throughout the day, or it may be present only on the first morning void. Some patients have also reported the presence of visible mucus threads, especially in the morning voids. On examination, the discharge may be grossly apparent, or it may only be detectable after gentle milking of the phallus. Patients with dysuria are more likely to have chlamydial infection. Patients with genital ulcers are more likely to have infection caused by the herpes simplex virus, and they may also present with other symptoms such as fever, tender inguinal lymphadenopathy, and headaches. The diagnosis of urethritis is mainly on examination, seeing the discharge, and also by a gram stain, which has importance, especially in differentiating between gonococcal and non-gonococcal urethritis, as well as the presence of leukocyte esterase on a sample of the first morning void. And this urine sample can also be used for nucleic amplification testing for identification of the pathogens. The EAU guidelines on the treatment of urethritis suggest the use of ceftriaxone and azithromycin for gonococcal infections, and we also have alternates present in the presence of cephalosporin or azithromycin allergy. For ceftriaxone, a 1 gram IV or IM single dose, along with azithromycin 1 gram oral single dose. And alternately, we have cefixime single dose plus azithromycin 1 gram per oral single dose. In non-gonococcal infections, we can proceed with empirical therapy in case of non-identified pathogens. In that case, the drug of choice is doxycycline at 100 mg BD dosage for 7 days. And alternatively, we can also use azithromycin, which is given in a dosage of 500 mg on the first day, followed by 250 mg for the following 4 days. Chlamydia trachomatis is treated with azithromycin or doxycycline, Mycoplasma genitalia with azithromycin, and in case of macrolide resistance, we can switch to oxyfloxacin. Ureaplasma urolyticum is also treated with doxycycline. The Trichomonas vaginalis is treated with metronidazole. It can be given in a single dose of 2 grams, or it can be given as a 500 BD dose for 7 days. For persistent non-gonococcal urethritis, after the first-line therapy of doxycycline, we can give azithromycin plus metronidazole. And after first-line azithromycin, we can use moxifloxacin plus metronidazole. So we will move on to cystitis, which is an inflammation of the lower urinary tract, specifically involving the bladder. It is broadly classified into complicated and uncomplicated cystitis. Over the course of our lecture series in the past few weeks, we have discussed cystitis in detail. The uncomplicated cystitis usually refers to lower urinary tract infections in otherwise healthy non-pregnant women, and complicated cystitis is associated with the risk factors that increase the risk of infection. These can be patient-related factors, such as functional or anatomical abnormalities, or it can be due to immunosuppression, or any UTI in men is considered complicated cystitis. cystitis may also be non-infective, and in that case, it is mainly caused by pelvic radiotherapy, which is called radiation cystitis, which compromises the bladder capacity. And also, it may be drug-induced, the primary drugs being cyclophosphamide, ketamine, and in the use of intravesical BCG, which we offer as a treatment to our patients with bladder growth. And we can also have interstitial cystitis, which is also known as bladder pain syndrome, and we will be discussing it shortly. The most common organism is E. coli, causing uncomplicated UTIs in women. Other pathogens include other members of the Enterobacteriaceae family, such as Proteus, Klebsiella pneumoniae, and others. The urinary tract infections usually present with burning maturation, increased frequency of urination. It may also be accompanied by nocturia, strong foul-smelling urine, and urgency, cloudy urine, or even microscopic or macroscopic hematuria. It can be evaluated on the basis of a urine dipstick test and cultures. On a urine dipstick test, we can see the presence of leukocytes, which are WBCs, which imply the presence of infection or inflammation. We might see nitrites on the urine DR. Nitrates are the common toxic byproducts in humans, but nitrites are present when bacteria is present. We can see, we might be able to see blood that may be microscopic or macroscopic. The management of UTI depends on if the condition is uncomplicated or complicated. The first line therapy for women is most, as recommended by the EAU guidelines for uncomplicated cystitis, is fosfomycin and the nitrofurantoin. And alternatively, we can also choose cephalosporins. And trimethoprim sulfamethoxazole is primarily used in treating UTIs in men and in female, and it is mostly considered if the local resistance patterns favor the use of trimethoprim. However, it should be remembered that it's not a drug to be used in the first trimester of pregnancy. Moving on to prostatitis. The prostate gland is subject to various inflammatory disorders, acute bacterial prostatitis being one of them. It is classified into 4 major types. First being acute bacterial prostatitis, and then chronic bacterial prostatitis, which is defined by symptoms that persist for at least 3 months. And then we have chronic non-bacterial prostatitis, which is also called which is subdivided into 2 types: the inflammatory CPPS and non-inflammatory CPPS. We will be discussing these. And then there is asymptomatic inflammatory prostatitis. The pathogenesis involves the entry of microorganisms, most commonly the gram-negative organisms, into the prostate gland. It may be direct ascending infections from common UTIs, or it may be due to instrumentation. Bacterial prostatitis is most commonly caused by gram-negative organisms, E. coli being the most common, and 5 to 10% of infections are also caused by gram-positive bacteria. There's a chance of progression to chronic bacterial prostatitis, especially if the causative agent is not timely treated. It happens because of the urine refluxing into the prostatic ducts and then accumulating into the prostatic urethra. The inflammatory and non-inflammatory prostatitis are also referred to as chronic pelvic pain syndrome. The underlying causes are not completely understood, and even the treatment involves multidisciplinary factors, and we will be discussing that shortly. Prostatitis is a common diagnosis, but less than 10% of cases have proven bacterial infection. The risk factors include the presence of lower urinary tract infections such as cystitis, urethritis, or the presence of functional or anatomical anomalies. Any urogenital instrumentation, be it catheterization, or intermittent catheterization, or even a prostate biopsy, can also put the patient at risk for acute bacterial prostatitis. As we discussed, E. coli is the most common cause, followed by Proteus and other Enterobacteriaceae, Pseudomonas, and certain gram-positive organisms as well. The patients may present with fever, malaise, increased frequency of urination, lower abdominal or pelvic pain. They may have erectile problems. It may be accompanied by nausea and vomiting. Pain may be felt at the tip of the phallus, and on examination, there is often firm edematous and tenderness noted on the DRE. The most important investigation in the evaluation of a patient with acute bacterial prostatitis is a midstream urine culture. The Mears-Teamy 4-glass test is a diagnostic tool that helps diagnose chronic prostate and pelvic disorders in well, and it involves taking urine samples before and after a prostatic massage. 30 minutes before the test, the patient should drink 400 ml of fluid, retract the foreskin, and clean the glans penis, and then proceed with sample collection. 4 different samples are obtained. The first one is labeled the voided bladder 1, which and presence of bacteria in this sample represent infection of the urethra. The voided bladder 2 represents involvement of the bladder, and the EPS3 is done after prostatic massage, and it represents the involvement of the prostate. And voided bladder 3, which also represents the prostate. This test is used to assess inflammation and the presence of bacteria in the lower urinary tract.
So just a word about this STEMI 4-glass test and acute as well as chronic prostatitis. Practically, I have never seen it happening, and in the last 30 years or so of my observation in urology. So, and particularly from the point of view of acute prostatitis, the classical teaching is whenever you have got a patient who is like in the middle age, which is like between 30 and 60, having symptoms of perineal pain, fever, and discomfort with lower urinary tract symptoms, then the first thing that comes to your mind is acute prostatitis. And whenever there is acute prostatitis, don't put your finger into the rectum, because this is something which is a no-go area during acute inflammation. So doing a test which is like a 4-glass test in acute prostatitis, just to know what is the kind of infection that the person has, I think in this day and age, the things are moving a little bit further. So rather than going towards the meticulous collection of sample, it's better to categorize patient into acute and chronic and then move on. Now, acute prostatitis can happen over chronic prostatitis. That is very important. For instance, if a person is like 60 years plus and having BPH and having a background of chronic prostatitis, then you can always see on a plain X-ray or on ultrasound that prostatic calcification is there. And this prostatic calcification is a telltale sign of chronic inflammation in the past. So if that is the case, then these are the cases which can present with acute on chronic prostatitis. And whenever this condition happens, don't do DRE in these cases, because again, this is not acceptable to the patient. So coming back to the clinical practice, you got to know what is the kind of situation the person is having, what is the kind of patient that you want to deal with, and what is the kind of medication that you want to prescribe. For instance, if you label a person having acute prostatitis, then you can't massage prostate. So you don't put him on weekly massage therapy for 6 weeks or so. That massage therapy is only for chronic prostatitis. So it is better to understand the whole process, why we do massage and why we don't do massage, rather than going from the very start as having a kill for the bacteria. The second thing is, most of the cases, even if you have got a very good antibiotic like penetration of osmotic, meaning to say that it doesn't go directly into the canaliculi of the prostate. So it is always a case that whenever you prescribe something, it is on a long-term basis. It doesn't affect the person's symptomatology right there in 24 hours. So it needs a little bit of time, maybe 10 days to 14 days of antibiotic therapy for these infections to just die down. So this is my take on the subject from a practical point of view.
Thank you, Dr. Asad. I wish to add one more thing about 4-glass tests. I have seen 4-glass tests in my residency by one orthodox urologist, but I also wish to add there was no change in the management of patient. We performed 2 times this test. Although patient was not going into urosepsis or something like infection further deterioration, but it does not change our management. It does not aid further anything. And as in the system, we work, everything costs a charge to patient that we sent 4 samples, and every sample cost for more than 2,000 rupees at that time. So 10,000 rupees, and it does not change our management, and it costs bother to patient also because it is not a simple test as it look like or be present in the presentation. So I think this is only in orthodox, or this is only in books, but not in practical urology in today's.
And particularly in Europe, if you go there, and not only in Europe but also in the Western Hemisphere, in America also, they have got a very large population of patients with chronic pelvic pain syndrome. So these are the patients, and these are a very sizable population. They go to their primary physician as well as to urologist with this kind of complaint, and they are within the age bracket of like between 30 and 50 or 60. So they are not per se BPH patients as such, but they have got problems, and they have got a lot of urinating problems, and they need treatment. You can't treat them with anticholinergics. You can't treat them with something called antibiotics because they don't have any infection. And since it's a very big population, and we don't see this kind of population here in Pakistan, they have got a separate kind of strategy for them. For instance, biofeedback, for instance, thermotherapy, and then things like that. So these patients, they do well with certain other treatment strategies which are not directly related to antibiotic therapy or antibacterial therapy. So chronic pelvic pain syndrome is an established group of symptomatic patients, no doubt, but we have to select this from the rest, and that is acute prostatitis. So this is my presumption on again on the subject, that maybe this group is hidden somewhere in the larger pool of our patients who come to us in this age bracket with a lot of lower urinary tract symptoms, and we treat them with, for instance, Genurin Fort or Europyrin. Now, these are the cases for not Genurin Fort or Europyrin. They need a little bit of more interrogation, question and answer. So if you ask them a lot of questions, then you might find someone who has got chronic pelvic pain syndrome. And these are the patients whose pelvic diaphragm is an spastic condition. So by having anxiolytics and treatments, for instance, very simple treatment of SIDS bath twice a day, it works rather than putting them on anticholinergics. So it's a different kind of a problem. It's a different kind of a strategy to get hold of it.
Thank you, Dr. Asad. And adding this to chronic pelvic pain syndrome, this was an experience shared by one of my colleagues who worked at UK for his electives. So there was a group of nurses, and they have added some social media group to person who are diagnosed with chronic pelvic pain syndrome or bladder pain syndrome. So they visit the patient at time to time, and they advise only these behavioral modification or biofeedback system. And he mentioned me that the patient responded very well for a long period of time, for a years or for months without pain. So these therapies work very well in this group of patients, and they do not start antibiotics without approving infections.
And just a historical fact, because this was my dissertation in FCPS, and that is the thermotherapy of prostate. So I worked on this special group of patients way back in the late 90s also, and it worked. So it worked, but provided we have got devices available. So this is a group which is still here in Pakistan also, but जिसमें मैंने कहा कि आपको अलग से वो categorize करना पड़ेगा, और फिर आपके पास strategy भी होती है.
Thank you, Dr. Sir. Moving on, like we discussed, the investigations will reveal peripheral leukocytosis, pyuria, bacteria. Now, of an positive blood cultures, the inflammatory markers may be raised, and the acute prostatitis can also raise the serum PSA level. The infection can further spread and cause complications such as bacteremia, peritonitis, chronic bacterial prostatitis, as we discussed. It can also lead to prostatic abscesses, which we will discuss in detail, and also an infection spreading from the local region. The treatment involves the acute bacterial prostatitis is usually managed according to the recommendations for complicated UTIs. For chronic bacterial prostatitis, we prescribe fluoroquinolone as the first line of treatment. The optimal daily dose is continued for at least 4 to 6 weeks, and other regimens include the use of doxycycline for 10 days, and it's only for patients with chlamydia trachomatis or mycoplasma infections. Azithromycin is used for 3 weeks for chlamydia trachomatis, and metronidazole is used for 14 days for Trichomonas vaginalis infections. The prostatic abscesses are less frequently encountered, especially with the appropriate management with antibiotics. However, they are most commonly seen in patients with compromised immunity, maybe due to diabetes or HIV or other causes. Signs and symptoms are similar to bacterial prostatitis, but they may persist for a longer period of time despite antibiotic therapy and involve systemic signs such as fever, malaise, lethargy. Again, the diagnosis can be made on transrectal ultrasound. However, it is not very commonly performed, especially as the ultrasound or a simple DRE may be painful for the patient. We can get a CT scan, which will show us non-enhancing fluid collection that can be multiseptated or an enhancing lesion. Some patients with acute bacterial prostatitis may need to be hospitalized for parenteral antibiotic therapy if they cannot tolerate oral medications, or if they've not responded to them, and they demonstrate severe signs of sepsis. And in such cases, IV levofloxacin or ciprofloxacin can be given with aminoglycosides. Moving on to bladder pain syndrome or interstitial cystitis. According to the EUA guidelines, it is the occurrence of persistence or recurrent pain perceived in the urinary bladder region, accompanied by at least one other symptom of frequency or urgency, with no proven infection or other obvious local pathology. It can be generally classified into, there are different classifications, and one of the classifications is based upon the presentations on cystoscopy, the ICBPS with Herner lesions, which is also known as BPS type 3, as categorized by the European Society for Interstitial Cystitis. And then there is ICBPS without Herner lesions, which is classified as type 1 and type 2. This is the representation of the Herner lesions. These are after hydrodistension of the bladder. We can see small petechial-like spots on the surface of the bladder, and these.
Just a word about these Herner ulcers. If you throughout your life, or maybe during your training period, if you happen to have a cystoscopy done by yourself and see the inside of the bladder by your own eyes, then you will see that these petechial hemorrhages are very peculiar hemorrhages, and they are actually written down as weeping ulcers. So it seems that the teardrops are the drops of blood coming out of these ulcerated spots. And once you see them, you will never forget them throughout your entire life, clinical life. And that becomes a picture at the back of your mind, and you will diagnose these conditions which are otherwise very difficult to diagnose. And once you diagnose interstitial cystitis, you can very well imagine the kind of natural history the disease is having. Because once it sets in, nobody can stop it, since it is in many of the instances an autoimmune disease, and it culminates into something which is like compromisation of bladder capacity. So it is not only cystitis, it is urethritis also. So the whole segment goes down. So it is very important to just diagnose these conditions. Again, this is very commonly diagnosed in the Western Hemisphere as compared to the global South. But it is all the more very important to know that there is nothing different between our two regions because of the population migration from one area to the other. But the diagnostic capability of a urologist should always be there. If you don't diagnose it properly, you won't be able to take out the biopsy. You won't be able to provide sample to the histopathologist to categorize into whatever the classification is. So it is very important as a urologist to give the first information report, and that can only be given by having a properly done cystoscopy.
Thank you, sir. As emphasized by Professor Asad, we know that it is very difficult to diagnose bladder pain syndrome. It is mainly a diagnosis of exclusion. Over time, there have been a lot of debates, and different societies have been made for addressing these patients who, and the main question has always been how to diagnose and how to label patients with bladder pain syndrome. The National Institute of Diabetes and Digestive and Kidney Diseases develop a diagnostic criteria for interstitial cystitis, and then these criteria was not meant to define the disease, but rather it was made to ensure that patients who suffered from these symptoms were always included in basic and clinical research studies and would be relatively comparable. The main idea was not to miss out on patients who may be suffering from such problems. And to be diagnosed with interstitial cystitis, patients may, as Sir said, cystoscopy is of utmost importance. The patients must have glomerulations on cystoscopic examination of classic Henner lesions, and they must have either pain associated with the bladder or urinary urgency. The bladder may be distended, is distended before the examination for glomerulations and Henner lesions. The glomerulations may be diffuse. They may be present in at least 3 quadrants of the bladder, or there may be at least 10 glomerulations per quadrant. The important thing to know is what excludes a diagnosis of bladder pain syndrome. A bladder capacity of more than 350 ml on awake cystometry, an intense urge to void with the bladder filled to 100 ml of gas or 150 ml of liquid, the demonstration of phasic involuntary bladder contraction on cystometry using the fill rate described, and the duration of symptoms being less than 9 months. The absence of nocturia, symptoms relieved by antimicrobial agents, urinary antiseptic agents, anticholinergics, or antispasmodic agents. So basically, patients that have responded to some form of therapy for their symptoms are not considered as patients with bladder pain syndrome. A frequency urination while awake of fewer than 8 times per day also excludes a diagnosis of ICBPS, as well as a diagnosis of bacterial cystitis or prostatitis, bladder or urethral stones, active genital herpes, uterine, cervical, vaginal, or urethral cancer, the presence of urethral diverticulum, cyclophosphamide or any other type of chemical cystitis, tuberculous cystitis, radiation cystitis, benign or malignant bladder tumors, vaginitis, and even age younger than 18 years. So there have been a lot of theories that have discussed the pathology of ICBPS. Most theories suggest that it is primarily due to a thinning of the endothelium, which makes the endothelium highly permeable and leads to leakage of urinary solutes into the urothelium. And this fragility of the endothelium also contributes to the pinpoint bleeding that we've discussed, and the presence of bladder wall ulcers. So as Professor Asad highlighted, and Dr. Karim also shared with us, the treatment is mainly focused at relieving the symptoms that the patients are suffering with. We do not directly jump on to antimicrobials or anticholinergics. We mostly encourage lifestyle modifications and coping mechanisms. Patients are advised to avoid caffeinated drinks, avoid foods that trigger symptoms, and most commonly reported are spicy foods, citrus fruits, alcoholic drinks. And as Dr. Karim shared with us, the presence of support groups that offer psychological, emotional support to these patients have played an important role since a very long time. Pelvic floor strengthening exercises are advised, and then there is also the intravesical instillation of glycosaminoglycans and local anesthetics. Other treatments that have been the use of amitriptyline and the use of Elmiron with environ, which helps to regenerate, not regenerate, but to regenerate the bladder lining because of the loss of the glycosaminoglycans. This is also what the intravesical installation of glycosaminoglycans does. I'm sharing a regimen that is currently used in Pakistan, in Islamabad at Al Shifa Hospital. They use this intravesical installation in patients who they've diagnosed with ICBPS. They use 2% xylocaine with the combination of sodium bicarb and heparin. This is instilled into the bladder for 30 minutes, and it is either done weekly for 12 weeks or bi-weekly for 3 months. They've seen promising results from this, although this is also a treatment that they are eventually planning to report based on their experience. But this is something that is being used in Pakistan. The use of oral cyclosporine is also recommended. The low dose is known to prove improvement in bladder capacity, avoiding volumes, relieves pain, and resolves urinary frequency. However, we should note that it should be avoided in patients who have hypertension. It can also contribute to gingival hyperplasia and facial hair growth.
Again, a word about cyclosporine. Now, cyclosporine per se is again something which is like from our own experience of renal transplantation, is something which is immunosuppressant. So it is from the class of CNI, and whenever it is used, it should be used with caution. So there are many other areas besides renal transplantation where cyclosporine is used, and it is being used only for the purpose of its anti-inflammatory action. It is not an anti-inflammatory drug. This has to be kept in our minds. It is something which is specifically discovered by people in Oxford and Cambridge when they were looking for something which makes the organ take up easier, meaning to say it makes the organ acceptable by the body. So the specific design of the drug is not for anti-inflammatory property of the drug. It is for immunosuppression. So this is because of the reason that you have written from the X, the cross sign. It causes hypertension, gingival hyperplasia, facial hair growth. So these are not only the side effects, but it is also something which is not needed. So whenever you are using it for the purpose of anti-inflammation, kindly ask your doctor whether it is absolutely necessary to take it or not. Otherwise, it is being used by ophthalmologists. It is being used by people from dermatology. So it is not a drug per se for all these areas. It is only for renal transplantation or for transplantation only.
Another suggestion that was made for ICBPS was the use of bladder fulguration. However, it is not the preferred approach, as it leads to it can compromise the bladder capacity. It exposes the bladder to perforation, and similarly for bladder hydrodistension, the effects of bladder hydrodistension are potentially short-lived, and they have long-term adverse effects. So these treatments for ICBPS have been evolving with time, and different measures are taken to try to relieve the symptoms of the patients. According to the EUA guidelines, we can only consider submucosal bladder wall and trigonal injection of Botox and hydrodistension if other intravesical therapies have failed. The last option is to resort to surgical management. The surgical management can involve urinary diversion without cystectomy, or we can also proceed with cystectomy. Now, these are very drastic measures, and they also bring a significant alteration to the patient's overall quality of life. However, these are only considered in patients who have long been suffering from the disease, and it has also been reported that many patients with ICBPS, because of their chronic pain and pain that is basically misunderstood, and usually these patients have gone to multiple doctors, taken multiple treatments. These patients have also been reported to have high suicidal ideations due to their long suffering of the disease. So the surgical management is taken as a last resort for such patients. Moving on to chronic pelvic pain syndrome. This is also referred to as chronic non-bacterial prostatitis that we discussed, class 3 and 3B inflammatory and non-inflammatory types. They usually present with more than 3 months of localized pelvic pain involving the perineum, the suprapubic region, the external genitalia, the lower back. There may be pain with ejaculation. We might encounter lower urinary tract symptoms, and these are symptoms usually difficult to treat. And the condition of patients with chronic pelvic pain syndrome is also quite similar to those with ICDPS. Patients turning to multiple doctors, multiple hospitals, having undergone multiple different types of treatments to no avail. The evaluation includes a detailed history. This is also, like we discussed, these patients need a thorough evaluation. A detailed questionnaire has been developed to understand their quality of life and to understand their symptoms. They mainly have symptoms of pain, and they have voiding issues, and their quality of life is significantly impacted. I've shared a chronic prostatitic symptom index questionnaire. This questionnaire mainly consists of 9 items and assesses the pain, the urinary symptoms of the patient, and their impact on the quality of life. The higher the score, the more severe the symptoms are, and it is a pain domain that is often considered the most significant for chronic pelvic pain syndrome evaluation. We assess the location of the pain, the severity and frequency of the pain, and if the pain is present during or after ejaculation. The different areas of the patient's complaints are considered, and these patients usually undergo thorough evaluations. There may be evaluations of the lower abdomen involving the reproductive organs, and multiple different teams may be involved. A semen analysis and culture is also considered along with the urethral swab, a urinary cytology if there is suspicion of malignancy, urodynamics to investigate voiding dysfunction, a cystoscopy, and even a TRUS or PSA is also considered. The treatments, as we discussed, mainly involves conservative therapy, as Dr. Kaleem discussed with us, that it is mainly the lifestyle and behavioral modifications and psychotherapy, pelvic floor physiotherapy. All of these provide a significant improvement to the quality of life in such patients. And then we can also consider symptomatic treatment, such as antibiotics in cases of proven infection, anti-inflammatory drugs such as NSAIDs, and pain management with analgesia, muscle relaxants. And these patients are also advised for prostatic massage, as we do for chronic bacterial prostatitis. This massage is done at least 2 to 3 times per week for 6 weeks with an antibiotic. And then local therapies like local heat therapies. And mainly what helps the patient is encouraged to continue. Thank you.